a bit view for rapid reporting. Then again, some interesting cases with a long design. Then finally, we will finish with BitCity cases. So as usual, we start. Yeah, thank you, M. I see that you are active today. MashaAllah. Okay, so let's start. Yeah, tophaceous gout, one of the good differential. So soft tissue swelling and tumefaction. So you will describe it as radiodense mineralized soft tissue lesion. So doc in the olecranon persa perfect, and it's good to mention that there is maybe some bony fragmentation here. So also it's important to comment in the joint space that it is maintained and no what you should mention in your report when you comment here.
No osteopenia, no osteopenia.
Good, about the density of the bone, no osteopenia, and about the articular surface, you should mention that there is no erosions. Yeah, because you want to differentiate it from, for example, if it is rheumatoid, so rheumatoid arthritis, maybe it will be there is erosion. Maybe they can put tumoral calcinosis as differential, maybe. In the MRI, the most important to look in the sequence of T1 or T2. The most important to look in MRI if you want to prove that it is gout. You will look in T1 or T2.
T2.
T2, yes, perfect, Nermeen, Dr. Fauzi. So T2 because you will find it like dark or low signal intensity.
Dark signal.
Yeah, also this adjacent bony changes. They mentioned that sometimes the tophaceous deposit that may erode the bone and mimic like some sclerotic changes. So you know that the gout is like something related to the urate metabolism, and you will search in the urine for something like uric acid crystals, either the joints or tissue or body fluids. Okay, so let's move on. So again, there is some fragmentation and soft tissue. The same case. And
CPP.
that if you find this, sometimes you can find bilateral bursitis. So the first differential diagnosis will be tophaceous, tophaceous gouty deposition, yes. Okay. Let's start with this short case, which is, I think it will be easy one.
Atlantoaxial dislocation.
Sorry, the voice.
Atlantoaxial dislocation.
Atlantoaxial subluxation, yeah. Why? Because you find something in the, what you find here? How you describe? There is widening, widening of the
anterior arch of the atlas and axis vertebra. Distant more than 3 mm.
So yeah, so there is enlargement or widening of the peridental space, which it should be like 3 millimeter in the adult maximum. And here you can see that it is widened, it is exceed this. And it's important to comment in the vertebral soft tissue if there is any abnormality. Yes. So if you find this widening, so you suggest atlantoaxial subluxation. Perfect. Then what you will put like the commonest cause or what one of the most common causes to be the rheumatoid arthritis. Rheumatoid, yeah, Nirmin, thank you. So rheumatoid arthritis in majority of cases will be the cause. It can be seen like 60%. So when you find patient with rheumatoid arthritis and you have cervical, you will go and search for it. And if you have atlantoaxial subluxation and you find the widening of the peridental space, you will ask in history about rheumatoid arthritis. What are the other causes could be of this case if it is not rheumatoid arthritis? You will ask in history, trauma, perfect, and deposition of calcium pyrophosphate, CBBD, or Down syndrome, perfect, Nermeen, had, nice. Yeah. They mentioned that in the pediatric age group, sometimes you can find it like a false widening. So they, up to which, how much millimeters is accepted in the pediatric age group? 5 millimeter, perfect. So until 5 millimeter in pediatric age group is accepted to see this widening. Okay? Until now, we are going smooth and easy cases. And let's have a look in this case. Is it the image quality is fine? Okay. So radiograph, frontal radiograph of both hands. You will comment in the bone density and the joint space, and if there is any erosive changes. So there is any abnormality in bone density here? Yeah, periarticular osteopenia or juxta-articular osteopenia. Perfect. And if you go to the joint space, do you see any narrowing or loss of joint spaces? Yeah, Justiana. So yeah, there is something in the carpal bone. Yes, in the proximal. So when you find proximal joint space narrowing, and you will suspect, I see that Justiana rheumatoid arthritis, doc. Yes. So again, you are going to search for one of the commonest cause. It will be rheumatoid arthritis. Okay. So rheumatoid arthritis, like the female gender, symmetrical distribution. And you will find the periarticular osteopenia. Nice. The differential diagnosis will be osteoarthritis, but you should find osteophytes or maybe, yeah, the joint space will be asymmetrical involvement if you have two joints. The psoriasis will be one of the good differential. So what is the difference between psoriasis and rheumatoid?
Psoriasis involve distal joints.
Yeah, psoriasis like distal. And what else about the bone density?
Bone density normal.
Yeah, most in the early cases are normal. So there is also periostitis. So yeah.
Pencil in cup appearance.
Perfect. Yeah, and it have many characters. So rheumatoid arthritis, it can involve the synovial joints and in symmetrical fashion, right? And you will search for the osteopenia and the erosion if you find any erosive changes. The characteristics, you can find something like subluxation, right? Joint space loss, as here, and you will search for any soft tissue swellings, right? So, yeah, the psoriasis, we will search for periostitis and new bone formation. I agree with you. Perfect. Yeah, and they like to mention that one of the most important sites to search in rheumatoid, the ulnar styloid process erosions and the metacarpophalangeal joints, right? And the proximal. Okay. So they mentioned that the second and the third metacarpophalangeal joint, it have the early changes of rheumatoid arthritis. Okay. The differential of gout will be also, maybe it can include it in differential diagnosis. Okay. They give you like, look in this changes, like erosion changes. It's very subtle. I don't know if you can see it or not, but they mentioned that there is some osteopenia, as you see here, and yeah, you can see the on both sides, and you suspect the erosions. Okay, let's have a look in this case, which I think it will be easier one again. So you have two sequences. This one is T1, and this one it is yeah, it is T2 fat suppression. So you have edema on both sides. Yeah, you describe it. Nermine, nice. And so in the T2, you can see the high signal intensity. T1 is low signal intensity. The characteristic location, you will ask in the history about steroid therapy, steroid use, right? Maybe. So insufficiency fracture, as you mentioned, Nermine and Doc and I see, it would be nice, the top of differential in this case. And in the X-ray, maybe you can find some osteopenia, or maybe you cannot find something, right? Sometimes if it is like in the subarticular, you can put a vascular necrosis, but in this case, I don't think you can put it. And you can put the osteomyelitis, maybe, but for bilaterality, I think it will be against the osteomyelitis. So yeah, Nermine. So why insufficiency fracture? The characteristic location, yes. And one of the most common sites will be the femoral neck, okay? History of steroid again. They like the subcapital region, the insufficiency fracture, and the bilaterality. Yeah, the bone density and the site. So if you find osteopenia or osteoporosis in the bone density, so osteomalacia will be one of the top differential. Okay. So let's check the anatomy. So this muscle is the sub. Do you agree that this is the subscapularis muscle? Right? Or not? And this one, it will be the supraspinatus and the infraspinatus and the teres minor. So this is what is called the rotator cuff muscles. So I see that Jermaine again. Okay, nice. There is edema in the teres minor. You mean this, right? This patient have no history of trauma. So you can find this edema with no history of trauma. And this should be fat suppression. Okay? So revise again your answer, Nermin. So this edema in T2 sequence. So this means that, yeah, I agree with you regarding the edema, yes. But later on, maybe it can have what is called fatty infiltration, yes. So now we have edema, and this is what is called denervation, yeah. Denervation, so start with edema, then maybe end with fatty atrophy and infiltration, yes. And this is what is called, as you mentioned, Irene, that quadrilateral space syndrome. So why quadrilateral space syndrome? Because compression of which nerve? They like it, the MCQ. It is compression of the
Suprascapular.
The axillary nerve, yeah, axillary nerve, and something called posterior circumflex humeral artery, which is passing through the quadrilateral space. Perfect. So this is like a triangle or anatomical region between long head of triceps and teres minor and teres major muscles, okay? Plus the humerus. Start with edema, as you see here, and eventually it will go to atrophy. This one is very easy one. It's come like antimony case. What do you think about it? Blount disease. Amna, nice. Welcome, Amna. Thank you. And Nermeen, Blount. So Blount disease, what it is? It is like as tibia vara. Yeah, tibia vara. It happened in the obese patient. Medial tibial metaphysis depression. You can find some fragmentation or osseous irregularity, and you will think about something called Blount disease, okay, or tibia vara. Sometimes it's symmetrical, and sometimes at this case it could be asymmetrical. They mentioned that the obese African, yeah, obese African in the history. Let's go more further. So this case, what do you think about it? This patient, yeah, Nermeen Berf. This patient is 14 years old, and I will tell you that he is obese patient. Then now is easy one, and also from the image you can see that the physeal or physis, the growth plate, you can see that it go down. So slipped capital femoral epiphysis, and if you try to draw the line here, that you'll find that the superior aspect of the femoral epiphysis, yeah, Klein line. It doesn't intersect this part, so it's easily you can. And this patient have chronicity, so chronic slip decapital femoral epiphysis, yeah. So it come in the, if you have pelvis of adolescent, then the most common abnormality, it will be this one, the slip decapital femoral epiphysis. So scaphy or slip decapital femoral epiphysis, the most common abnormality in hip in adolescence age. Males are more common than females. Typical presentation in age of 13. Sometimes it have bilaterality, like in 40% of patients, it can have bilaterality. And the surgery here will be something called surgical pinning, yes, pins. In the early stage, just you can find the widening of the physis, yeah, and maybe some osteopenia. It can, if after trauma, then the most common differential will be Salter-Harris type 1. Okay? Yes, doc, perfect. So this is the line I can show you. Okay. Another case, the history will be the clue, so I will not give you the history. Welcome, Ala. So I see two answers. Which one you agree? Finally, and where is it? I see two answers. Which answer you would like to agree, and where is this answer? Which one? So if we mention that it could be osteoid osteoma, where is it? Like Ala mentioned, where the osteoid osteoma? Where is it? Then now I can tell you that the patient have pain, which is nocturnal pain, and this patient takes salicylates, and he resolve after, but the pain is recurrent. So until you find either anyone can draw, where is it? I will wait, but I can tell you that osteoid osteoma, it happened in the young male. So if you find perfect, nice. I see a lot of drawing with red and sorry, with blue and okay. So I agree with you. Okay, thank you. I agree. I agree now totally. So now I can show you the city, and thank you for this drawing. And you can see that yeah, this is the osteoid osteoma here, and you prove that that's nice. Yeah, and we mentioned before that the radio frequency ablation, it will be the treatment. Nice. So this is the nidus, central lucency here, and relieved by salicylates. This is in the history of this patient. Okay, nice one. So you have three images now. Let's try to solve them. This is axial T1, T2, and T1 with contrast. So this patient, she is young female patient. What do you think about this? What is your differential and how you describe it? Nice. So you will think that maybe it is like a cystic lesion, and in the enhancement you will think that it have little marginal enhancement, mild enhancement, yeah, and it is coming in the dorsum of the wrist. So it is a common location of what is called ganglion cyst. So ganglion cyst is like the differential, which is part of myxomatous collection, or which is yeah, that come beside the tissues, either joints, ligaments, or tendon. The cyst will be sometimes enhancing, like what you see now, especially at its margin. Sometimes you like to differentiate between synovial cyst and ganglion cyst. Yes, Ala, perfect. Which is the ganglion cyst is like a fibrous, and the synovial cyst is like synovial. Yeah, contains synovial fluid. But the other, which is the ganglion, is lined by the fibrous tissue. Anyway, it is like, it will be ganglion or synovial cyst as a first differential. The location is common. So typical location, it will be the dorsum of the wrist, so you can know it. And sometimes it can happen in the scapholunate ligament. The treatment will be surgical resection. Okay, so you should describe it, especially the location, and if it has any relation with the tendons and the adjacent bone. So the most common, you can say by through the MCQ, the most common soft tissue mass around the wrist will be the ganglion cyst. So they consider it like this. Okay, let's go further. And yeah, I think this one maybe you see it in the practice one day, especially who write the MSK cases. Is very easy one. Yeah, Baker cyst. Baker cyst is like to be between the gastrocnemius muscle and semimembranosus tendon. They call it sometimes the popliteal cyst. The most common site to be here. It is like fluid-filled semimembranosus medial gastrocnemius persa, located in the medial popliteal region of the knee. Okay. They mentioned that there is some coexistence between the posterior horn of medial meniscus and the Baker cyst. The posterior horn of medial meniscus tear and the Baker cyst. Yeah. Thank you. That the most important to check that if it is ruptured or not, if it is complicated, like there is any synovial proliferation, internal hemorrhage, or rupture. Yeah. Perfect. We mentioned that the weakness of posterior joint capsule allow the cyst to be connected with the posterior knee joint. Yeah, this is how it happened. Yeah. Thank you. Okay. This patient have what is called chest trauma. So this is the X-ray. I will show you that maybe is not very obvious in the X-ray, so I will go to the CT directly because it should be like a short case. So what do you think about here? Perfect. So the sternoclavicular joint, you can see that there is posterior sternoclavicular joint dislocation, and you will check for the vessels if there is any disruption. So the CT contrast, the CT post contrast here will be very important. Yeah. So sternoclavicular joint dislocation. Yeah. It can be anterior or it can be posterior, like in this case. They mentioned that the anterior dislocation is much more common, and but the posterior dislocation at this case, it is more dangerous because you have the great vessels behind the sternum. So it is much more dangerous to see if there is any nervous or mediastinal structures that injured, like trachea, esophagus, whatever. Okay? The most important to request, if you just suspect from the X-ray, that you will go and mention that the CT with post contrast, the most important one. Okay. Yeah, you can see here that in the X-ray again that the right sternoclavicular joint is, yes, the right sternoclavicular joint and clavicular head directly like down, right? Is a bit directed down to relative to the sternum. Is very subtle. Yeah, I agree with you. I will show you maybe this one, maybe this much more zoomed here. So the right clavicular head directed caudally. Okay, but you should add it in your checklist, especially if this patient is in trauma and you didn't find anything positive. Also, you can suspect if there is some soft tissue widening here. Okay. We have 1 minute. We can finish this case, then go to the second step of our session tonight. So this patient have like a mass in the left thigh. What is your differential diagnosis? And if you want to request something, what you request to check, which image or which sequence you would like to check. So this is a T1, sorry, this is a T2, and you can find that this is very high signal in T2, and there is, yeah, perfect. So you'd like to check the pre-contrast and compare it with the post-contrast and see if this lesion is enhancing or there is anything else. If it is high in T1 by its nature, then you will think about maybe hematoma or something high in T1. But if you find it like low signal in T1 and in the post contrast it is enhancing, then the most common lesion or differential you will put, it will be something malignant. Yeah, like fibrous histiocytoma, sarcoma, synovial sarcoma, whatever. But the most important to check the post contrast and the pre contrast. Like this one, you should check the pre-contrast to check if it is high before the contrast or just after the contrast will become high. Then it will be like soft tissue mass, enhancing mass, and it is different from the T1 high signal lesion. So the T1 high signal lesion, you will include hematoma as a first differential. especially if this patient have trauma. But in this case, already he gave you the post contrast to show you that this patient have enhancing soft tissue mass lesion. That's mean that you will go more in the malignant side, or at least it should be a tumor. Okay, soft tissue mass. Then you will go and go with the differential of soft tissue masses. Yeah. Okay. Yeah, like sarcoma, malignant fibrous histiocytoma, and so on. Okay. I think, okay, we can take this one. This is before you start to describe, check first which sequence are you. So this is T1 and this is T2, and you can find that T2 is very high signal in T2. So I agree with you, Nirmeen, Ala, Shayma, Dok, again Shayma. So fat splitting sign. So that's mean that it's like a fusiform appearance, and nerve sheath tumor will be the best differential in this case. And this patient will come to you like history of paresthesia. Yeah. And you can, in the T1, you can note that the signal intensity, it is look like the muscle. So it's like iso-intense, and it is homogeneous. The good thing that why you think about the nerve sheath tumor, because of the location and the appearance that located adjacent to one of the nerves here, which should be the radial nerve here, for example. And as you mentioned, that the split sign or fat split sign, that you can see the fat which have characteristic appearance along the margin of the mass, give you the impression that you could put it as, yeah, the differential. So the peripheral nerve sheath tumor, it should be schwannoma or neurofibroma. So neurofibroma will be more common, and the patient, as we mentioned, will have like paresthesia, and it have slowly growing pattern. So this patient will have like enlarging mass, but slowly growing. Myxoma, Shayma, is very good differential to put. So schwannoma, yeah, it arises from the something called the epineuron of the nerve, and the fusiform appearance, it gives you the impression that you talk about peripheral nerve sheath tumor. Sometimes in the large nerves, it can be large mass, and sometimes you cannot differentiate it easy. But as you mentioned, it means that the split fat sign is good characteristic. Yeah. And the target sign as well. Yeah, perfect. Yeah. The target sign and the split fat sign. But to differentiate between schwannoma and neurofibroma is very difficult. Okay. This is like antimony case, is easy one. Is easy one. I will just mute for 1 minute. Yeah, it is coalition, unitraquetral coalition. Sorry, I will just mute for 1 minute and come back. Okay. ماشي. Okay, thank you. Okay, bye bye. Sorry, I have important call from the hospital, so yes. So we okay, the voice is fine now. So yes, it was the case as you mentioned exactly. It was fibrous dysplasia. We discussed it much times. So what do you think about this case? Now we go to the rapid reporting mode again. So is it easy? Right humeral, yeah, pathological fracture. Nice. I can imagine your answer. It's okay because I know. Yeah, yeah. Pathological fracture. Perfect. So what do you think about this one?
Sclerostosis.
What do you think about this one? Can you revise again? Okay, I will try to. I think just if you go to the most common thing that happen in the wrist, you will find it. Yeah, at least you can mention that it is distal radial fracture. Yes. So if you mention it is distal radial fracture, so this is very nice from you. Thank you. Our big stars. Nice. Again. What is this? I think now it's a bit easy that you can find the buckling here. So this is one of the commonest rapid reporting rapid reporting slides in pathology. They like to show you the distal radius fracture. So yeah, distal radial fracture is one of the most important checklist items that you check, especially in young age. For example, if you have in this case, you will go check for the distal radial fracture. You will go check for the radial head and the shafts of the ulna and radius. You check for the distal and proximal radio-ulnar joints and so on. Okay. Sometimes it can come to you like a subtle. It's very subtle in the rapid reporting, but you need maybe to make some zooming. I will try to show you. For example, if you make zooming here, you will find that yes, there is something going here. Just to show you something, you in the rapid reporting cases, you have maximum 3 slides that you can be wrong, and you have like there are 30 cases, and about half of the exam is like normal. So this make you more confused that which is normal, you can confuse it with the abnormal. So if, for example, if you go and mention in this case that is normal, then it will be wrong. Okay, so you should check slowly and rapidly in the same time. Yeah, I mean in accurate way. Yes. So for example here, what do you think about this case? I will wait the first star who can catch the abnormality. I will give him like 10 flowers, 10 big flowers. The first star who catch the abnormality. Nermeen, revise again, please. Ala. Yeah, it is fracture, but where? Hi, where? No. Maybe. Yeah, I understand that maybe. Yeah, Ala, perfect. Yeah, clavicle. Yeah, this is the clavicle. Yes. So this is a fracture, but it is not in the. Yeah. So 10 flowers, big flowers for Ala and Nermeen. Okay. Again, one of the most important when you go to the upper limb, if you have any picture of the upper limb, check for the clavicle. Sometimes is obvious like this one. Okay, and sometimes it's sometimes it can be like subtle. Again, in rapid reporting, they like to show you the clavicle. So again, it's clavicular fracture. What do you think about this? Upper limb. So in rapid reporting exam, again, you have 30 cases. Half of them at least, or maybe less than half, or whatever. It is like normal. So, but you should be used to check the abnormality. So the abnormality here is the AC dislocation. Perfect. So you can check the AC joint, the acromioclavicular joint, and it is dislocated. And you know that it have some grades, grade 1 and grade 2 and grade 3 and so on. Yeah. So this is AC dislocation. At least you can mention this. So in the hand, one of the difficult rapid reporting images, because it takes from you a bit long time, because you need, for example, to make zooming for bone by bone and try to find the abnormality. But for the training, I will help you to find the abnormality. So if I told you that the abnormality in the fifth finger, where exactly it should be? Yeah, it will be fracture, sure, but where exactly? Yeah, fifth what? Yeah, so the fifth metacarpal, perfect. So this is here. Sometimes if you check one view, maybe you cannot note anything. But if you check the second view, that you will see that there is some malalignment here. And then you are going to mention that it will be fifth metacarpal fracture. Yes. Okay. Yeah. Again, it's fracture, but very subtle. Yeah, I will help you on this. Distal, yeah, nail bit. Perfect. So you get it. Nice. Okay. So what? Where is the abnormality here? Again? Yeah, the radius. Perfect. I imagine that you want to tell it the answer, so yeah, I agree with you. Okay. Here it will be the styloid. Perfect. Styloid process fracture. One of the good sites to check either the radius, the distal radius, or proximal radius in the rapid reporting. So what do you think? The abnormality, is it in the proximal radius or in the distal radius? What do you think? Is it in the proximal radius or the distal radius? This is the pediatric patient. So when you find the pediatric patient, you are going to activate your checklist. Yeah, so it is in the, nice, perfect in me. So it will be in the proximal radius. Yeah, angulation. So the fracture of the pediatric, you can see that it is sometimes just angulation. Yeah, elasticus fracture. Thank you for this expression. Okay, nice. Is it good for you this time? Because I am in. I want to make voting to continue this rapid reporting. Is it okay for you? Every time we can take some cases to train you and train together in this, or is it difficult? So it's up to you. I mean, we can take some cases every time if you agree with this. Okay, thank you. Okay, so what do you think? Again, when you check in the pediatric age group, you will check proximal. Welcome, Sarah. Perfect. You will check for the proximal radius or distal radius, and here in the proximal radius, the neck exactly, you can see the fracture. It is easy. But to be honest, Sarah is more than green stick because, yeah, it is more. It is fracture in the radial neck fracture, yes. Again, angulation, radial neck fracture. You can imagine here that is very subtle. You cannot even say that it is involved. But here, in the other view, that's why you should check both views. Even in the real practice, you should check the both views to be sure that they are affected. Okay, perfect. Yeah. If you check here the lateral view, maybe if you are lucky, but to be honest, I cannot see the fracture. But when I go to the other view, you can see it easy here. So radial head fracture. That's why you should make zooming, change the window, try to find the way to check. Because if you report like this one is normal and another two, then you will get failed in this exam. Okay, again, a lot of types of radial head fractures. This one I think is easy, and you can see even the fragment is going up. Okay, and this one, where exactly the fracture? Can you describe it? So, ulnar, perfect. Proximal ulnar. You can see it's clearly that in the proximal ulna. Maybe here you can imagine it, but here is more obvious in this view. Nice. So what do you think about this? Yeah, the fracture in the proximal humerus. Yes, perfect. Here, very subtle. But in the other view, that's why you should check for both views until you reach the differential, the diagnosis. Is it easy one here? I think it's easy one. So proximal phalanx fracture. You can saw it easy. Yes, clear. What happened here? enchondroma or lytic lesion, and it have pathological fracture. Perfect. It have pathological fracture. What is your differential here? This is hand. What do you think about it? What is your big differential, top differential? Revise again. Perfect, I bet. So it will be like osteomyelitis. You can see even the soft tissue here is much soft tissue, and you can see the osteopenia and the something called the ambulacrum and so on. Yeah, perfect. So osteomyelitis will be the good differential here. This one is easy one, if you want like it. The rise bodies, so it will be intra-articular loose bodies. Yeah, it will be what? One of the good differential to put, or one of the ossified rise bodies. The joint space, no erosions. Here, no osteopenia. So, and yeah, synovial chondromatosis, perfect. So synovial chondromatosis, one of the good rise bodies. Okay, again, check much and much. Sometimes it is in one view, subtle. But if you go to the other view, you can see it well. You see the fracture well. You need to make some zooming until you reach the fracture or the diagnosis. Here, now I think after training, it become easy to you to detect that this slide, it is, if it is come to you as a short or rapid reporting, what it will be. Yeah, clavicular fracture. Now, I think this training give you the points that always you check for the most common location of the abnormalities first. Then after that, go and further and check slowly for the uncommon. You remember keratoid, right? And you remember to check for the ossification site of keratoid. So capitulum and radial head, internal, external, trochlea, yes, keratoid. Olecranum. So what happened here? Perfect. Medial epicondyle avulsion. 1, 3, 5, 7, 9, 11. Perfect, Sarah. Thank you. So now you can see the avulsion of the medial epicondyle. So medial epicondylar avulsion. Nice. Now you have your checklist. I think now if I give you one elbow of pediatric patient, you will go check for the radius, check for the anterior humeral line, radiocapitular line, then check for keratoid, for example, and ensure that you will detect it easy for you because you have your checklist. You have something that you, in systematic way, you reach the diagnosis. This one is not easy because I think need like this zooming that you suspect that there is lytic, humeral shaft fracture. You will see that the end of film, the edge of the film down maybe you can see something here. Maybe it's not very easy, but yeah, you can see even the periosteal changes here, and there is soft tissue changes. Yes. Is it clear? Now you are going the differential of lytic humeral lesion and with sclerosis. So metastasis will be one of the good differential, or infection like osteomyelitis. You remember when we talk in the first season of musculoskeletal about the difference between the perileonate and the leonate dislocation, right? So now the time to practice. Where is it, or what is this one? Yeah. So do you remember that the cup, the relationship with the capitate, and the leonate should be in this location. So when you find the leonate away from its site, so do you think that's something called leonate dislocation? Yes. Okay, perfect. Leonate dislocation. I see Shayma, Nermeen, our biggest stars who have the previous session with us. So now it is easy for you. Thank you. Yeah. Again, when you have the lateral elbow, after you check for the lines, you will check for what is called the anterior and posterior fat bed sign. So the posterior fat bed sign, when it is present, you will go to mention that it is supracondylar fracture. Perfect. Again, supracondylar fracture. Time to change. Time to change. Okay. Now we are going to check something like this case. It is like more in the long cases. So you need to make description. Sure that for us it will be quick description. Try to collect the finding. Write shortly what you find. Then finally to get the answer. I think this image will be the key for you. I will stop like moment here. Sarah. No. I think you will have to revise again. Yeah, so try to find the big abnormality here. So it is a sternal pathology. So describe it, how you can describe it. Yeah, when you describe it, describe the bony changes with permeative and destructive pattern. Nice. And don't forget this soft tissue. And you can see that the skin here is denuded or incontinuous interacted here. Perfect. And there is fat smudging and stranding. So all this, if you don't describe in your report, I think if you are in the exam, it will you lose some marks. So try to be used to make the description and to describe well. Then you know the time to interpretate. So the interpretation will be either metastatic or lymphoma, nice, leukemia, nice, and osteomyelitis. So let's stop in osteomyelitis. You have a clue here that maybe it is osteomyelitis. You will check if this patient have any immunocompromised or history, of diabetes. And then one of the good differential that you can put osteomyelitis as a good differential. Perfect. And this one, it was sternal osteomyelitis, and you can see the soft tissue it changes. Okay, I will show you the answer. So external osteomyelitis, yeah, this is the diagnosis with inflammation. Okay, let's have a look in this one. Time to see some long cases. I wish the quality is fine. This is the updated website and it have very nice cases. So we have about 2 minutes. So I will take voting for 10 seconds. You would like to continue for 20 minutes more or 10 minutes more or stop after this 2 minutes? 10, 20 or 0? 10, okay. Anyone else? Okay, so I see that 10 is like the lucky number today. Okay, so what do you think about this? Okay, I agree with you. I see that everyone like 10. Wow, that's really nice. Okay, so what do you think about this case? Do you see an abnormality? No? Check again, Sarah. Nermeen, don't rush to the answer, especially in the long cases, because sometimes it make you block to check for anything else. So describe better first. I think, for example, here, you will describe that there is maybe soft tissue nodular lesion, and this lesion, it take like not just one nodule, it is like multiple, and they are confluent together. You can consider it a thickening, yes. Then go to the interpretation and start to think about anything else. So here again, soft tissue thickening along the gallbladder. He's a bit like the margin, inside margin is hyperdense. Okay. This is the BIT-CT, the original or the original picture of BIT-CT. You cannot see the black white picture, but what is white here, it is 10 minutes. Okay, everyone agree with 10 hours. So let's check for this 10 minutes. In the BIT-CT, it have like, what do you see here? This is the original picture of BIT-CT. What we saw always, this is the inverted image. So yeah, what you see here, it is like in the BIT-CT have what? Low uptake or high uptake. See the urinary bladder, we know that already, the urinary bladder from previous sessions, that this is like normal excretion. And yeah, there is high uptake. And also the heart, it has physiological uptake, but is high, very high. But now you can consider that the gallbladder. So now, Nermeen, are you again with your differential or you change it? Now go to the CT image and tell me what is the most important differential you got after you see the very high uptake of this gallbladder thickening. So what the top differential? Is it carcinoma or just cholecystitis with this appearance like a mass? Yeah, but with this appearance of very high uptake that involve all the gallbladder, then the carcinoma will be the top differential in this case. Do you agree with me now? Yes. So important when you describe and put it in the differential. Okay, and you can see now that the answer, it is gallbladder cancer in the CT and BCT. Something very small but very bad for the patient. Yeah, and if you detect it early, maybe it can be helpful for this patient. Okay. Okay. So I don't know if we saw this case before or not. I will see now. I don't think so, but if anyone saw it before, just let me know to skip it. Okay. So do you see abnormality in the CT? Can you describe it where exactly? I will stop now browsing and try to find it. Did you find it now? Yeah, thank you. Who drew this yellow? I like the yellow color, so who drew this? Yes, okay. So this is the abnormality here. Yeah, soft tissue, nodular thickening, soft tissue lesion in the wall of the stomach, GIST. One of the most important differential will put GIST. Can you just remove? Thank you. And imagine that, yeah, there is some extension beyond the pancreas, but in the coronal image, I think is like more obvious. In the bit coronal image, you can see the fused image. Yeah, GIST will be one of the good differential, especially. And you see that in the FDG, it takes very high uptake. In the FDG, it takes very high uptake. Okay. So the answer, as I see that you know it already, this is a gastric GIST tumor. The gastric GIST tumor. Nice. I see that our stars today are still in good condition. That's good. So maybe we can show them this case. That means that they can solve it as well. I trust in them. Okay. Yeah, I agree with you, sir. I agree with this differential. In the previous case with GIST, you can put gastric carcinoma and lymphoma, and the histopathology will be the golden standard in such cases. Yeah, I agree with you. Let's go to this case and see how it can be. I think, yeah, you can describe this lesion, which is in the perihepatic region. Yeah, pleural based lesion and pleural effusion, or ascites, sorry, both pleural effusion and ascites. And there is soft tissue thickening here in the pleural side. Again, peritoneal nodules. And what else? Where is the clue? If you consider all this, like until now, the are metastases, it can be peritoneal carcinomatosis with pleural and peritoneal affection. It can be what else? If it is not peritoneal and you have this image. Okay, because we are stuck to finish in 10 minutes, so I will tell you the answer.
If you tell us the bone window to see any bone lesion.
I wish I can find, but this is selected images, so they didn't. or sorry. But you can imagine that there is some sibling here, surgical or sutures, and it's
Yes.
related to the IVC, and you find the left kidney in this level, but you are missing what in the fat of the right kidney? You are missing the right kidney. So it is, yeah, it is metastatic renal cell carcinoma to the muscles, bone.
Bone and
Yeah. So
yes.
they like to show you this case in the Viva. In the Viva, yeah, because already you have missed the right kidney. It should be in its place. And already you can see the fat and the surgical. So this means that, yeah. And you remember that we mentioned that renal cell carcinoma, it can give everything. So it should, you should search for bone metastasis, and this one, peritoneal or pleural metastasis. It is hypervascular metastasis. So yeah, it can give you everything. I think in Radiopedia there is one very nice case, and it is metastatic even to the pancreas as well, similar to this case. Maybe I will ask Nermeen and Ala and Marwa to prepare, like, and maybe if anyone like Sarah, Shayma, and anyone would like to share with us. Next session, it will be in Tuesday, if you agree, or Wednesday, whatever. And I will ask you to prepare some cases in musculoskeletal. I think it will be your lecture. Then you will send me the cases, the link of cases. You can choose any source like Radiopedia, whatever. And I like to choose, you choose like nice cases to be teaching. If you just, everyone can choose 1 or 2 cases maximum, so to not be loaded for you, to not be load for you. So, and just send me, I will explore them. And for example, Nermeen will send me something, Ala will be the one who answer, so everyone prepare his cases to ask the other. We can make it like a bit fun and play. I wish that Dr. Fauzi also with us, Abbas, and anyone who would like. I will open, inshallah, and thank you. See you, inshallah, next Tuesday. See you. Assalamu alaikum. Assalamu alaikum. Bismillah and good evening. Continue today, inshallah, again, a revision of musculoskeletal. And I see everyone is excited to give the answer. So nice. I think is nice answer. Macrodystrophia lipomatosa. So what is the description of macrodystrophia? They like to show you like sometimes as anti-many case, is even it is like not common case in the practice, is a rare case, but you can say that it is like in the pathology is like a local form or, of gigantism. So it is gigantism, localized form of gigantism. You can consider it like overgrowth of fibroadipose tissue. You can see here the affected bone and the soft tissues are enlarged, and sure that the blood flow that going to this region or this area, it will be increased as well. It can affect any part of the body, but usually they show you in the hand or the foot as this case. Okay, so the description will be like you should mention hypertrophy or enlargement of the osseous structure plus soft tissue, as you see here, and you can see even the bone density is changed either with the lucency and it's changing the trabecular pattern or sclerosis as in here. So this is what is called macrodystrophia. Okay, yeah, sometimes in childhood, usually it can be recognized in childhood. Yeah. Okay, let's shift to so another case. So I'm searching for, I think this one is fine. So the description will be like you can start your description first before the diagnosis. So what do you think? How you describe it? Okay, so is it like just very articular, or you can see that it's like maybe, yeah, there is osteopenia. Perfect. And how you describe this? What do you think about the ulna? What happened here? Yeah, there is some, you can slanting or penciling, yeah, narrowing or thinning of the ulna here, and you can see some fragments here. Yes. And in the other view, I see that there is subluxation in this metacarpophalangeal joints are subluxated. Perfect. And maybe I can show you now these things. Yeah. So also you can see here what is going on in the shoulder or in the elbow. Yes. So what is happening here? How we describe it? Yeah, try to describe, because in the report, when you, for example, in long case or in Viva exam, you should be used to use Marwa, yeah, to use some descriptive words, not just science that you don't, I mean, it's good that if you mention famous sign, okay, but the most important, how to describe it. So, for example, you should comment in the density, in the articular surface of the joints, if there is any narrowing, there is no narrowing. So you should have your checklist and try first to describe, okay? Then after that, you reach your differential diagnosis. So yeah, maybe you can mention that there is some narrowing in the joints, maybe mounting to be fused, maybe. And the most important, doc, perfect, that there is soft tissue calcifications here. So soft tissue calcifications here and here, some of them are here and here. Yes, okay. And we should comment in the joints that there is narrowing joints and there is, yeah. Then now your time to go to the differential diagnosis. So if you mention that there is soft tissue calcifications, and probably some of us, maybe you can imagine Yeah, that there is some acrosteolysis here. I know that the images are not very clear, but yes. Okay, and in the big joint, like the shoulder, elbow, what happened? So they mentioned that the conical shape of the ends of the digits mounting to reach acrosteolysis. Okay, soft tissue calcifications, acrosteolysis. I see that the differential going with rheumatoid, systemic lupus, nermine, perfect. And yes, nice, you saw it. So there is distal clavicle erosions. Yeah, nice, perfect. So distal clavicle erosions, and what else? Yes. So now, what is the most likely to be? Is it rheumatoid, scleroderma, systemic? Do you have any clue? Maybe if you imagine that the acrosteolysis is evident in this case, maybe you can put like scleroderma. Yes, Sarah, you can put scleroderma as your first top differential. Yeah. So when you mention scleroderma, don't forget to remember something called CREST. So what is CREST syndrome? CREST is like C for referring to calcinosis, perfect, and R for Raynaud's phenomena, esophageal abnormalities, sclerodactyly, and telangiectasia. So this is what is called CREST syndrome. So skin, gastrointestinal, lungs, kidneys, heart, all this can be affected in this disease. So you will search for them, okay? Scleroderma is one of the most important entities in musculoskeletal exam, either in FR or in EDIR. Okay, they like it, so yeah. Let's go to another case. Yeah. So this is like selected image from the foot, and maybe you can imagine that it is T1. What do you think? Okay, so T1. So what is your description and your, yeah, so you will think that there is a soft tissue here between the third and the fourth. So try to describe with me, Marwa, Aina, nice Antimini, but try to describe. So soft tissue signal, and in the T1 you can see that is low signal. Do you agree? Marwa, perineural fibrosis, nice. Okay, so perineural fibrosis of Morton's neuroma. So what's the most important sequence you would like to see after the T1, the regular T1? Yes, so T2 and the post contrast, because if you want to confirm that is Morton's neuroma, it will take like enhancement. So it will be like a soft tissue, and you can see that it will be in the post contrast enhancing. This is the pre contrast, and this is the post contrast image. Yeah, and sometimes you can show it in the coronal image as well. So yes. Anyway, in the axial, it is more obvious here. This one. So what is Morton's neuroma? It is like a type of fibrosis, which is perineural fibrosis. Yeah. They mentioned that is like neuroma of interdigital nerve. One of the most common nerve problems that happen in the foot. Okay. They mentioned that the location is regular, that it is coming in the third common digital nerve. Mid-age woman, the type of patient, usually. Sometimes the third, sometimes the fourth, digital site. Okay. So Morton's neuroma. Yeah. Let's go to another case. Let's just, this is to show you very quickly what it is. Who the first star will catch it? Is easy one. Yeah, it is C1. Yeah, C1 fracture. Perfect. C1 fracture. So C1, posterior arch of C1 fracture. Okay, C1 fracture. So atlas fracture, C1 fracture, posterior arch. Yes. And you should search for any other association like subluxation or, yeah. So what do you think about this one? Is it hard? Okay, so stress fracture, how you can recognize it? Like a focal area of sclerosis. Yeah, and you can see like a lucency passing through the cortex. So you can, yeah, you can imagine that it could be stress fracture. Well, this is what's called longitudinal tibial stress fracture. Yes. Nice. Nice, Nermeen. Marwa. Yeah. So it is straight. You can confirm it by MRI. Sometimes it's not very easy, especially with this MRI low quality image, but you can see that there is a fracture line, especially if there is a stare image. You can see the edema, the marrow edema. You can recognize, in this case of ankle, could you recognize the fracture easy? Where is it? Yeah. Yeah, there is the Taylor, what is called Taylor neck fracture, which is an easy case, yes. perfect. So again, we mentioned already this, when you find soft tissue calcification with acroosteolysis, you will put differential diagnosis, and your first differential diagnosis will be a scleroderma. So this is another case of scleroderma. Yes, and you have like many differential diagnoses. Sometimes they like to show you it can happen in every place. Like this, I will show you that it can come even at the peripatellar space. Then you should mention that the causes here, scleroderma, and the similarities that make this appearance. I will just show you something. Okay. So just to show you this description. So this is the causes of acroosteolysis. You can see that you have very good list of causes that make acroosteolysis, including what is make the tuft resorption, like scleroderma, and the most common one. It can be thermal injury, hyperparathyroidism, psoriasis, midphalangeal resorption, and periarticular erosions. And you can see that scleroderma again. Okay. Let's show you this case, which is a bit difficult case, but we can try to describe. I wish that the image is clear. So how you describe it? Try to have systematic approach when you talk. So for example, start, is it skeletally mature patient or not? So you can mention that this is radiograph, both hands, skeletal mature patient. Maybe you can mention the bone density as a first, then try to comment in the articular and in the periarticular and soft tissue, and if there is any fractures, if there is any. Oh, so you have your checklist and try to find it. Okay, so I am waiting any positive answers. So imagine that, yeah, good start, Sarah, that there is lines that look like fractures, and this fractures is like bilateral rather symmetrical, right? So these fractures including the metacarpals, right? Nice. So there is maybe some osteopenia, like generalized osteopenia as well, right? So fractures, Marwa, perfect. Transverse lucences. So now try to think what can you do after. And this fracture, if you look carefully, you will find like there's some sclerosis, like sclerosis through this adjacent bones. Yeah. So sclerosis, yeah, sclerotic edges. Okay. So osteopenia, let's try to think now. Let's have like a method that maybe it can help. Now you have a checklist, you will try to fulfill the checklist, and after that you will get some titles. For example, here the titles you get that maybe there is some osteopenia and there's fractures, and this fractures is a bit strange for you because it is bilateral and maybe symmetrical, right? So now I think you will not think about trauma, because trauma is like a bit in local and in maybe in one hand. If he make like trauma for both hands, it can be, yeah, but maybe he's a nervous person or someone who is very aggressive. But anyway, and she looked like a female, so I wish that he's not her husband. So anyway, we will not go in social aspects, but at least remove the trauma from your big list. So what do you think about other lists? Now you have two titles. You have like osteopenia, and you have bilateral fractures, or you can say bands of lucency. Okay. Then try now to find yeah, differential diagnosis until you reach I am waiting. I see some suggest psoriasis, maybe, but you know the psoriasis have some articular changes. Also rheumatoid will have the same. Hyperbara maybe, but you know the hyperbara have a lot of criteria that not typical for this case. Nice, Nermeen, perfect. Osteomalacia, good choice. So now when you go to osteomalacia, do you remember what is the characteristic with osteopenia? And the fracture is not fracture, they are something called loser zones. So loser zones again with osteomalacia, yeah. So osteomalacia, it can happen with something called loser zones. So what is the, yeah, this is vitamin D deficiency, okay? And you have many causes of vitamin D deficiency. So osteomalacia is like systemic disease, right? Which affect the skeleton, mature skeleton. So it's good when you describe this case, you show like this is the mature skeleton, or the X-ray of skeletal mature patient, yeah. And it affect the mineralization, right? Mineralization, we mentioned this before, of the osteoid, yeah. The main cause is like vitamin D deficiency, yeah. And what is the difference between the rickets and osteomalacia? Both are like vitamin D deficiency, but what are the main, one of the main differences? Yeah, that the osteomalacia have no affection for the growth plate, yeah, and the age. Rickets usually in child, but both are for vitamin D deficiency. So when it affects the growth plate, you can think about rickets. So the non-specific criteria of osteomalacia that you find osteopenia, and maybe some coarse trabeculation, okay? This is non-specific. When you find the specific criteria, which is lucent bands, what is called pseudo fractures, like what you see now, so it is this is the loser zones, okay? They mentioned that the loser zones usually perpendicular to the cortex, and it is incomplete fractures. So you can imagine that maybe that it is incomplete transverse fractures, okay? Unless it have like true fracture, it can develop like a true fracture. So it is pseudo, so it is incomplete fracture until you have. The thing that make you think about it when you find it like symmetrical, bilateral symmetrical, okay? Also, sometimes the sclerotic margin, this means that it takes time and would have chronic aspects. If you have an oral exam, they will ask you about the common sites, and probably they will show you some images of the common sites. So what are the common sites of the loser zones? Yeah, the pubic rami, inferior pubic ramus, medial femoral neck. So inferior pubic rami, the proximal femur, the medial, and I see the scapula. So let me show you the scapula then. So here, so you can see the scapula here in the, they say the axillary border of the scapula. So you can see easily this, what is called loser zone, and also in the, so the axillary border of the scapula or lateral border. Sarah, perfect. Nermeen, Marwa, thank you. We mentioned the femur, the ramus, the inferior pubic ramus, also the ribs, and the acromion, and finally the ilium. They like to mention in the MCQ that the difference between Paget and loser zone. Which one will affect the outer cortex and which one will affect the inner cortex? So, yeah, the Paget like the outer cortex, loser zones, they like the inner cortex. Remember that it is pseudo fracture, incomplete fracture, yes. So what is inner? It will be the loser zone, Sarah, perfect. What is outer? They like the Paget. But osteomalacia can have pathological fracture. Perfect. Let me show you this case. Try to go in a systematic approach to hopefully to reach the diagnosis. I'll just try to make it clear for you. So I see, yeah, someone try to answer. Frontal radiograph, like he is old, maybe male, no breast shadow. You can find this. So how you describe it? Try to describe it. Let's help you. So it's solitary or multiple or solitary lesion? Solitary. And you like to mention that it come like a bony lesion or pulmonary. So I see that you mentioned that it's bony lesion come from the rib. So nice. Then the next will be, is it look like aggressive or is indeterminate? They mention also that there is maybe a fracture here or all the fracture. Maybe you can consider it like all the fracture. Okay, so what do you think about it? What the differential diagnosis? I see Nermeen mentioned that metastasis in chondroma, it can be good differential, nice. So metastasis, for example, lytic metastasis, it will come from we mentioned it could be renal cell, breast, bronchial, thyroid, the common lytic metastasis, and fibrous dysplasia is good, nice near me. Enchondroma, perfect. Also brown tumor, then you will look for hyperparathyroidism, and you will look in the neck if there is any sutures or there is any operation for hyperpara. And the plasmacytoma, perfect, Maro. So plasmacytoma, you will think about multiple myeloma. The single one from it will be the plasmacytoma, perfect. So the differential diagnosis will include plasmacytoma, lytic metastasis, fibrous dysplasia, brown tumors. So nice. They mentioned that the chondrosarcoma, it can be, but the commonest primary malignant tumor. But you know that the chondrosarcoma, the location also near the costochondral junction, it have calcification. So this one is not typical. But you can just mention in discussion if they ask you. Okay. They mentioned that it's good to look for two regions. If you have single rib lesion, look in two regions. Look in the neck region, as we mentioned, to look for sutures. If this patient, for example, have either hyperparathyroidism and he did like operation, or thyroidectomy and he have, for example, lytic metastasis. So you can think about this if just he show you the X-ray. The other region, it will be the retroperitoneum. And look also again for sutures if this patient could be renal cell carcinoma. So rib lesion with sutures in the neck region, it can be metastasis or hyperpara, or if you go down and you look for the anything that give you a clue that this patient renal cell carcinoma, again it can be metastasis. Okay, I know that, but for the exam they like show you something like this, or at least you think about it. Let me show you something here. So, for example, here, this patient have multiple lesions, which is like what is called cannon pool, lung lesions. But do you see anything else? 1, 2, 3. 1, okay. 2, 3. Then 4, maybe. Do you see 5? I mean, you at least you see something here, and you see the rib here, right? You see 2 ribs here. Do you see any rib here? So I think now you can imagine that there is lytic or vanishing of this rib. You cannot see this rib with the metastasis. Yeah. So now when you find lung, which cannonball metastasis, and lytic rib affection